the second talk actually will be given by Dr. Chiang Nai-Jung. And Dr. Chiang was a graduate from the National Defense Medical University, and currently he is a faculty in the National Institute of Cancer Research, and his affiliation for the clinical service in the National Chiang University Hospital and Department of Internal Medicine. And today she's going to talk about the TS-1 in cholangiocarcinoma. I think you all well know that the S1 actually is a very active pyrimidine that used only in Asia area, but not in the Western. But I think this compound actually very interesting for the treatment of cholangiocarcinoma. So please.
Thank you, Dr. Chen's introduction. Today I'm pleased and glad to have this opportunity to introduce S1 in cholangiocarcinoma. This is supported by TTY Biopharma. Actually, I will introduce the Japan study, including 2 phase 3 study and our TCO study and adjuvant setting about ASCO study. This is the incidence of worldwide of cholangiocarcinoma. You can see the incidence of cholangiocarcinoma in Asian countries is more higher than Western countries. And especially in Asian, the incidence of intrahepatic cholangiocarcinoma is more than extrahepatic cholangiocarcinoma. This is a little difference compared to Western country. In Western country, you can see the incidence of extrahepatic cholangiocarcinoma is higher than intrahepatic cholangiocarcinoma. For Taiwan, our incidence is 4.7 per 100,000 people. Actually, before 2018, there is only one phase 3 study, ABC02, demonstrated gemcitabine plus cisplatin is better than gemcitabine in overall survival benefit. And the other meta-analysis study just tell us gemcitabine plus protein doublet chemotherapy is better than gemcitabine alone. And the other meta-analysis study show that gemcitabine cisplatin is effective in non-Asian patients and as well as in Asian patients. Actually, this is a study demonstrating the development of S1 in pancreatic cancer. Actually, S1 was already approved in Japan since 2007. And in 2013, there is 2 small randomized phase 2 study to establish gemcitabine plus S1 is better than gemcitabine or S1 monotherapy. And in last year, they published 2 phase 3 study. One study mentioned that GS is non-inferior to GC in overall survival benefit, and the other study showed us triplet chemotherapy GCS is better than GC in overall survival benefit. I will introduce this trial later. The first study is S1, small phase 2 to evaluate PK of S1. And the other study is S1 registration study. This study only includes 40 patients, but show S1 is a promising agent in the advanced biliary cancer and with acceptable safety profile. And thirdly, study S1 is approved in Japan for biliary cancer treatment. And then they want to combine gemcitabine plus S1, and this called GS. GS regimen means gemcitabine use 1,000 milligram per square meter day 1 and day 8, and S1 is 60, 80, 100 milligram per day based on BSA, and 2 weeks on to 1 week off. And S1 alone monotherapy means 80, 100 and 120 per day, 4 weeks on, 2 weeks off. And the results show GS is better than S1 in terms of 1 year overall survival rate and overall response rate and progression-free survival. However, the overall survival is not different. Although GS is better than S1 monotherapy, but you can see the incidence of grade 3/4 neutropenia rate is higher, up to 60%. And after they established gemcitabine plus S1 is an active agent, active regimen in pancreatic cancer. They initiated a study, JACOB 1113, or called FUGA-BT trial. They want to evaluate the non-inferiority of gemcitabine S1 compared to gemcitabine cisplatin with primary endpoint of overall survival. And the GS regimen is derived from JACOB 0805, just we mentioned that. So you can see the overall survival. The overall survival is totally overlap for GS and GC. It's a primary endpoint, and GS is non-inferior to GC in overall survival benefit and with good tolerability. And in terms of median progression-free survival and response rate, it's totally equally between two regimens. So if we compare the subgroup analysis, so you can see in terms of median progression-free survival and clinical significant AE or SAE, the GS is better than GC. And you can notice the dose intensity of two regimen is only 75%. And the other, especially for GS, is GS did not require hydration. So if your patient cannot tolerate hydration, maybe GS is an alternative regimen for this kind of patients. And about Taiwan, we since 2003, our teachers and our intendant also initiated many IIT study to promote our pancreatic cancer treatment. Initially, we have gemcitabine plus high-dose FLO and FOLFOS, and in 2015, we have an IIT study to use GEMOS with or without sacituzumab. And in 2017, we have a regimen called modified GS in pancreatic cancer treatment. What is modified GS? It is an alternative GS regimen. We can see the JACOB 0805 or JACOB 1113 is GS regimen is gemcitabine used 1,000 milligram per square meter day 1 and day 8, and S1 used for 2 weeks on, 1 week off. But we, in our study, we use modified GS. We reduce the dose of gemcitabine and to 800 milligram per square meter only on day 1, and we elevated the dose of S1 to 80, 100, and 120 per day, and we use 10 days on, 4 days off, and 2 weeks as a cycle. Because we believe gemcitabine will induce more grade 3/4 neutropenia, so we reduce gemcitabine dose and elevate the S1 dose. So we initiate S1 gemcitabine plus S1 in pancreatic cancer called T1308 study. Actually, this is a S1 registration study in Taiwan, and our primary endpoint is disease control rate with stable disease lasting 12 weeks. Finally, we get, if we look per protocol per population, well, our response rate is almost 24%, and our primary endpoint long-term disease control rate is almost 17%, and more than 60% our primary endpoint. So finally, these studies meet our primary endpoint. The median progression-free survival is 5.6 months, and median overall survival is 14.5 months. If we compare to GS regimen in JACOG 00805 and JACOG 1113, you can see our toxicity profile is better than GS regimen, including grade 3/4 neutropenia, grade 3/4 thrombocytopenia, and all-grade nursing vomiting and anorexia. Although our response rate is a little lower compared to GS, our response rate is 24%. However, our overall survival is 14.5 months and is quite equally compared to JACOG 0805 or JACOG 1113. Especially if we compare to GC in BT22 or our previous study compared to GEM-OS, our modified GS is also have better toxicity profile and better response rate versus 15% in GEM-OS and 20% of GEC in BT22, and significantly higher overall survival compared to GEM-OS in TD1210 and GC in BT22. And after GS is well established as a first-line treatment in pancreatic cancer, the CATCH-BO 1401, they want to elucidate GCS, a triple chemotherapy regimen, is better than GS or not in terms of overall survival. And GCS regimen means gemcitabine 1,000 milligram per square meter, cisplatin 25 milligram per square meter, and you can note they just use 120 milligram per day, 1 week on, 1 week off. This is called GCS regimen. So finally, they meet the primary endpoint. GCS is better than GC in overall survival benefit. However, the p-value is 0.3466. But the hazard ratio is almost 0.8. However, if you look median progression-free survival or response rate, the GCS is significantly better than GC. And there's an interesting point. If you look at JACOG 1113, the response of GC is 30%. Compared to GC in this study, only 15%. So we can find that there's a big heterogeneous about the same regimen in different studies. However, the conclusion is the GCS is better than GC in overall survival benefit. So it's very interesting. If you use AAA regimen, the grade 3/4 neutropenia rate did not increase a lot compared to GC. This means maybe you reduce the time of gemcitabine and cisplatin. But the diarrhea, stomatitis, and rash caused by AS1 is increased compared to GC. But interestingly, the incidence of sensory neuropathy decreased because you decrease the frequency of cisplatin. This is a trend to have triple chemotherapy in Asian country. How about the Western country? They use gemcitabine, cisplatin plus ablation. So this is a trend of treatment. Let's start from doublet chemotherapy to triple chemotherapy. So how can we do and how can we develop our own study? So we have a regimen called SLOG regimen in pancreatic cancer. It means gemcitabine plus oxaliplatin and AS1 1 week on, 1 week off. And we already initiated as a phase 1/2 SLOG regimen in metastatic pancreatic cancer, and with promising efficacy. So we want to test if SLOG regimen can work in pediatric cancer. So when we initiate IT study called T3217, we use SLOG compared to GC as the first line treatment in advanced pediatric cancer. The primary endpoint is 6 months progression-free survival rate, and this is ongoing. And the other prepare IT study, just previous speaker, Dr. Ming-Huang Chen, initiated, we call the NGS study. Means nivolumab combine gemcitabine and AS1 in advanced in BTC. Because our modified GS is quite tolerant and with limited toxicity. So we use our modified AS1 regimen plus nivolumab fixed dose 240 milligram, and this protocol is under review, and we hope we can initiate study at Q2 this year. And how about the adjuvant study? I believe yesterday many speakers focused on this kind of setting. So we already realized the currently standard of adjuvant therapy in resectable pancreatic cancer is the capecitabine. And the other study we hunger for is ASCO study. ASCO study, we use AS1 versus observation in cholangiocarcinoma. And the other study is gemcitabine plus cisplatin versus capecitabine. So I will just mention the ASCO study. This study is complete enrollment, and we hope we can have this result this year. It's used as one of the adjuvant therapy in resectable pediatric cancer. Actually, they only want to enroll 350 patient, and finally they revised protocol and elevated the power. So finally the case number is 440. The primary endpoint is overall survival. So this is my conclusion. And in addition to gemcitabine and cisplatin, GS or GCS will be considered to serve as one of choice of first-line treatment in advanced pediatric cancer, especially in Japan. And the modified GS show acceptable efficacy and limited toxicity. And this kind of characteristic is easily in combination with other therapy. For example, we can use triple chemotherapy or add on targeted therapy, immunotherapy, or use this kind of regimen to add on local regional therapy. So for the adjuvant setting, capecitabine become the standard of care in pediatric cancer. And ASCO study will elucidate the role of adjuvant as one. Finally, I want to thank HR and SKU BTC team and our director, Dr. Chen, and we have outstanding surgeons, including Dr. Singh and Dr. Lin. And in addition to, we want to thank a GI specialist and do emerging ERCP or something like that, outstanding surgeon. Finally, we want to thank our patients to give us opportunity to participate in our study. Thank you very much.